Hi, my name is Kim Blair, and today we're going to discuss colorectal cancer. And this year, nearly 145,000 Americans will be diagnosed with colon cancer. It is the third leading cause of cancer-related deaths in the United States, and an estimated 50,000 people will die this year alone. Many of these lives could be spared if more of us got screened. Today, we're going to discuss colon cancer, and by the end of the presentation, hopefully you'll have a good understanding of what it is, where it comes from, signs and symptoms, and diagnostic tests that can be performed for early detection and prevention. Overall, we want to get across the importance for us as nurses to educate the public about early detection. We can make a difference if we all do our part. This is a highly curable disease if it is caught soon enough. According to Lewis, about 90% of new colorectal cancer cases are detected in people older than 50, and about 25% occur in patients with a family history of colorectal cancer. Hereditary diseases account for about 5 to 10% of colorectal cancer. Lynch syndrome is the most common hereditary inherited form of colon cancer. Adenocarcinoma is the most common type of colorectal cancer. Most colorectal cancers begin as adenoma polyps that arise from the mucosa lining of the lumen in the colon or rectum. And as it grows, the cancer progresses down from the tip of the... As the cancer grows, it becomes invasive and penetrates the muscularis mucosa. Once through the muscularis mucosa, tumor cells gain access to regional lymph nodes and the vascular system and can spread to distant sites. The most common sites of metastasis are the regional lymph nodes, liver, lungs, and peritoneum. Since venous blood return leaving the colon and rectum flows through the portal vein and the inferior rectal vein, the liver and lung are the most common sites of metastasis. The cancer spreads from the liver to other sites, including the lungs, bones, and brain. The cancer can also spread directly into adjacent structures. The growing tumor can obstruct the bowel. Now for the signs and symptoms of colorectal cancer. A change in bowel habits, including diarrhea or constipation, or a change in the consistency of your stool, rectal bleeding or blood in your stool, persistent abdominal discomfort such as cramps, gas, or pain, a feeling that your bowel doesn't empty completely, weakness or fatigue, and unexplained weight loss. Many people with colon cancer experience no symptoms in the early stages of the disease. When symptoms do appear, they'll likely vary depending on the cancer's size and location in your large intestine. In more advanced cases, abdominal tenderness, macroscopic rectal bleeding, palpable abdominal masses, and hepatomegaly can be present on physical examination. If you notice any of the symptoms, especially blood in your stool, or experience changes in bowel habits, make an appointment to see your doctor. Now, Susan's going to discuss the diagnostic tests available and available treatment modalities.
Hi, my name is Susan, and today I'm going to be talking about the diagnostic studies and the treatments available for colon cancer. So the first thing you want to do is maintain a patient history and get everything that you can through that to see if they have any family history of colon cancer. Also, you want to do a routine physical exam. Should include a digital rectal exam, as polyps can often be felt in the rectum area. The American Cancer Society recommends people who do not have an established risk factor begin having colonoscopies every 10 years after the age of 50, a fecal immunochemical test yearly, or a double contrast enema every 5 years. A guaiac stool test is also a good test to detect colon cancer, as it can find blood that's in the stool. The sigmoidoscopy or colonoscopy are the two finite means of diagnosing colon cancer. Cancer or cancerous polyps have been removed during the procedure of a colonoscopy, and a confirmed pathology report can indicate if you have colon cancer. Treatments that are available depends on the stage and the location of the cancer. The most common treatment is surgery. Also, chemotherapy is a possible treatment, and it's a systemic treatment that uses medication to kill cancer cells. Radiation also shrinks tumors prior to surgery and can kill cells after surgery or relieve pain or symptoms. Also, monoclonal antibody therapy, which is a biological therapy, can be used in conjunction with chemotherapy. Lizette will be coming in to talk to you about prevention, patient education, and a nursing plan of care for colorectal cancer. Thank you.
Education, risk factors, and nursing plan of care. Prevention for a client experiencing alterations in immunity. We're going to monitor their eyes and nose as well as elimination patterns. We're going to provide pain medication. We're going to observe closely for visible signs of bleeding. If they have surgery, we're going to do post-op care. We're going to maintain NG suction, provide pain medication, monitor output from their drains, provide wound care, promote measures to decrease respiratory complications. So it's very important that we turn our patients every 2 hours, teach them how to do deep breathing, coughing. We're going to get them ambulating, and we're going to do splinting. We're going to slowly progress their diet and monitor the response, so make sure there's no nausea and vomiting involved. We're going to provide patient education regarding activities, so no lifting. And we're going to teach them about the need to use the stool softeners to avoid straining. We're going to provide ostomy care and teaching, as well as support clients with disturbed body images. We're going to monitor for high-pitched bowel sounds, as well as hypoactive bowel sounds, since that can be an indication of bowel obstruction. We're going to monitor their H&H very closely, as well as their stools for evidence for bleeding due to perforation or erosion of the walls of the intestines, resulting in lower gastrointestinal bleeding or peritonitis. We're going to teach patients about risk factors, so it's very important to know about their family history of colorectal cancer, as well as inflammatory bowel disease for more than 10 years, personal history of colorectal cancer, familial adenomatous polyposis, cigarette use, alcohol consumption of 4 drinks or more. We're going to teach them about red meat consumption, about 7 servings or more per week, obesity, hereditary of non-polyp colorectal cancer syndrome. We're also going to provide emotional support and psychological support, since the patients experience a lot of diarrhea, constipation due to altered bowel elimination patterns, pain due to difficult passing of stools because of the partial or complete obstruction from the tumors. We're also going to talk to them about fear due to the diagnosis of cancer, surgery, or any therapeutic interventions, possible terminal illness. We're also going to talk to them about their ineffective coping due to the diagnosis of cancer or side effects of treatments, or even their poor prognosis. We're going to do a lot of patient education, that the recovery is very long, and there's a 5-year survival rate for stage 4. There is a recurrence of cancer, possible, very painful, debilitating, and demoralizing. They might need palliative care depending on their prognosis. If the patient receives surgery for colon resection, we're going to teach the patient about the perineal area, that it might not be completely healed before discharging home, and home care by the nurse and ET nurse in an outpatient clinic in a wound management might be needed. We're going to teach the patient that the wound will be irrigated and debrided, that the skin around the area will be assessed for loose hair, and shaving of the area will be needed to prevent developing of a chronic drainage sinus. We're also going to teach family and the patient themselves how to do wound care and the procedure to take assist bath at home. And now Jessica will talk about therapeutic communication, healthy diets, and myths.
A diagnosis of cancer is an extremely frightening time for a patient. Nurses can help patients and their families develop a hopeful outlook throughout the stages of the cancer process. In order to support a cancer patient, nurses should be present and available, especially during difficult times. Listen to a patient's feelings. Have a caring, open, and honest attitude. Provide relief from uncomfortable and distressing symptoms. Help the patient to set both short and long-term goals. Assist the patient to go on doing activities that they enjoy. Use touch to provide comfort. Sometimes a hug or a hand squeeze is more powerful than words. Foster hope. Hope varies depending on a patient's cancer status. For example, one patient may hope for a cure, while another hopes for a peaceful death. A positive attitude is not scientifically proven to cure cancer, but it certainly increases quality of life for a patient and their loved ones. I'm going to read a couple of common myths about colorectal cancer. Colorectal cancer is a man's disease. Truth. Colorectal cancer is just as common among women as men. Another myth. Colorectal cancer cannot be prevented. Truth. In many cases, colorectal cancer can be prevented. Colorectal cancer almost always starts with a small growth called a polyp. If the polyp is found early, doctors can remove it and stop colorectal cancer before it starts. To help lower your chances of getting colorectal cancer, get to and stay at a healthy weight, be physically active, eat a diet with lots of fruits and vegetables, whole grains, and less red or processed meat. Limit the amount of alcohol you drink. Don't use tobacco in any form. Another myth. Age doesn't matter when it comes to getting colorectal cancer. Truth. More than 90% of all colorectal cancers are found in people who are 50 and older. Another myth. It's better not to get tested for colorectal cancer because it's deadly anyway. Truth. Colorectal cancer is often highly treatable. If it is found and treated early, the 5-year survival rate is about 90%. Thank you very much for listening to our cancer. I don't know. Stop it.
Stop.